everyone. Welcome back to the QueerCME podcast. I'm very, very excited to have Colt with me today. Colt, I will let you introduce yourself.
Cool.
I think that's best.
Yeah, thanks for having me. Colt St, he and they pronouns. I know Crystal through the work of healthcare and taking care of our community. I'm openly trans, transitioned 20 years ago. Wow. And I'm a family doc and a child family psychologist, and I practice in upstate New York.
Yeah, can you fill our audience in on how you ended up with both a PsyD and an MD? Because I'm always quite, is appalled the correct word?
You should be. So yeah, it's a PhD in clinical psychology and an MD in medicine. And so I always thought I was going to be a physician, but then I donated blood and fainted and then developed anxiety about like blood things and like was fainting a lot. So I was like, probably need to not be doing that. So let me try a different career. And so I went into psychology and I was transitioning my first year of grad school there. And quite luckily, they teach you like how to deal with like blood anxiety in that program.
Amazing.
So I learned to deal with that. And then also from like my first class in the DSM and learning about gender identity disorder, which is what it was called back then, I was like, this is appalling. And then I started reading the research and I was like, this is appalling. And I was like, wow, I'm going into this program where I can learn research and I can publish things that would be not terrible. Even though I didn't want to go into research, I just wanted to do clinical practice.
Mm-hmm.
I was like, I feel like an obligation to my community because I'm in this, accessing this space. And so I decided probably midway through psychology grad school that I was also going to go to medical school because my dissertation was finding that testosterone treatment over time had great effects for mood, quality of life, decreasing stress, like all, like it was good, which we already knew, but I needed to do research and get some data on that. So my dissertation was one of the first longitudinal controlled studies of testosterone. And I was like, I need to prescribe this. And we need all kinds of care. You know, I'm from Texas, so I was from the South, and there was not much going on. I could get folks ready, do letters for all sorts of things, but then, especially if they were youth, I didn't really have anyone to send them to in the Houston area. I was sending people to Galveston and across state lines. So I was like, why don't I just learn to do this? And then luckily, since my mom is a physician, she was very excited because apparently there's like a whole culture if you're a doctor and your kids, here we go. So she said that she would help me pay back student loans. And so I said, then, yep, I'm going.
Yeah, amazing. So yes, listeners, a PhD and an MD, and how long did you practice as a clinical psychologist before you went back to medical school?
Sure. So let's see. So grad school was 07 to 13. Fellowship was till 2014. And then I started med school in 2016. And practiced all throughout med school on the side, mainly because people needed PhD letters for surgery. And so and then I had some like family type consultation type work as a psychologist just to help parents understand those sorts of things. But I haven't been practicing therapy because that requires a lot more availability and bandwidth than I've had. So I've been practicing psychology the whole way through. And really my first rotation was in 2009 when I started seeing clients in psychology.
Okay, amazing. Thank you for filling us in. And then you very specifically created a program. Well, one, you've been like a contributing author for WPATH for a couple, like definitely 07 and 08, or SOC7 and SOC8. What are we calling them now? Right?
I was an author on SOC8 and some of my research informed SOC7. That's right.
Okay. There it is. Great. Thank you. And then you created a program called Gender Asset, which is like a online on-demand program that mental health providers can take and learn how to write affirming surgery letters. Do I have that correct?
Yeah, so it's an acronym. It stands for the Gender Affirming, Supporting, or Supportive Surgical Evaluation Tool. And it came out of my work. Originally, I did a fellowship at the VA with veterans, and they were just starting to figure out a more formalized way of meeting with folks who were interested in starting hormone therapy or continuing it through the VA. And so part of my fellowship, they had me come up with like the assessment or evaluation for that. And so I had sort of some basics and used, what different folks across the country had been using, looked at some of the WPATH trainings, and I was like, oh, I need to make this better. And so I had that back in 2013, 2014. And that's when I started to say, to experience with the change with the SOC7, fewer of the hormone providers were requiring a letter from a mental health provider to start hormones. So I was like, okay, well, why don't we just figure out how to morph this so it's specifically about supporting access, informed access to surgery. And so that's how we got the Gender Asset 1.0. And it's got a cute workbook that came with it.
Oh, yeah.
Back in the day. Yeah, but it was, this is 10 years old. And so this training is real old. We've actually just stopped having it available to be sold because it's so out of date at this point.
Yeah, but I feel like you made an updated version. Am I wrong?
You are right. So I partnered with my colleague, Dr. Zoe Amaro Jimenez, they, he pronouns, who's a psychologist out in the Bay Area, I believe. So West Coast, California. And we worked together for about 2 years. So 1 year before the new standards came out, 1 year after. So that's like 2021 to 2023. To update the gender assets. So the Gender Asset 2.0 is what we've created, and it's just finished being edited, and now we're on beta testing. So it is almost ready, but it's so different because with the new standards of care, it does no longer do you have to be specifically a mental health provider to evaluate and provide a letter for insurance for surgery, and no longer does it recommend a letter at all. It just says if the system that you're in requires a letter. And so we changed it so much because we wanted it to be accessible to, anybody from a care navigator to nurses to, of course, therapists as usual, but also to physicians, to anyone who is involved in the process of helping our community to access surgery. And, since the first one, I've gone through residency, right? So there's a lot more medical knowledge in there. There's a lot more deep dive on each surgical procedure, because one of the critiques that I've always had is you're having a mental health provider practice outside of their scope of care and sign off that a person is informed in the risks and benefits of this surgery.
Oh, yeah.
But that's inappropriate, right? That the surgeon should be doing that.
Absolutely.
And so that's what we're working on.
Yeah, right. And it was like the mental health provider was supposed to say that the person's informed of the risk and benefits, and the person can't have a consult with the surgeon until they have that letter. So they can't have actually talked to the surgeon in depth about the risk and benefit. Yeah. I always, my letters, because I would write them as a medical referring provider, and my letter would say like, the patient is like grossly informed of a broad overview the risk and benefits with the surgeon to further this conversation. Like it was quite, it's like, no.
And it's part of the history of WPATH where, the people who were very first starting in the 70s were taking a lot of professional risk to even take care of us because of transphobia. And so surgeons were like, well, we'll only get on board if we have a mental health provider who is going to do all this part of things. And mental health providers were just like, we just want to help, whatever we need to do. But unfortunately, because of that, the way that things were arranged, there was an expectation for mental health providers to know a lot more about medicine, which is inappropriate and outside of the scope of care. And so a lot of what we talk about in 2.0 is practicing inside your scope. But at the same time, our community deserves access to like really great information. And while some surgeons have that as part of like, if it's a big team and it's a system, they got it together, that's not the experience of a whole lot of folks, specifically in the States is kind of where we're talking about. But, practicing in Texas, the surgeons I would send folks to before the Crane Center got there, like there was no like coordination of care. It was just sort of like, I was the only person they talked to. And then they went and saw the surgeon for like 3 minutes and then had surgery. And I was like, oh, our people
Yeah.
deserve, better information and to really be prepared to recover from surgery. Because for me,
Yeah.
that's right. What I found is the most important thing is, most people can get to not everybody can get to a healthy space where they're approved for surgery from like the cardiac perspective.
Mhm.
But in terms of what all you need to recover, a lot of folks get surprised by that. So we spend a lot of good time going over that information in the Asset 2.0. And I've created a free and accessible YouTube video. There's a series of 6 20-minute videos on my YouTube, Dr. Colt, that goes over preparing to recover from surgery. And it's
Amazing.
directly accessible by community, because that was like the big thing is community needs access to this kind of information, and making sure that those of us who are giving whatever letters or whatnot, make sure that that person gets the education so that they can make informed decisions and prepare to recover well.
Absolutely. Yeah, we have up on the QueerDoc website. Nora did like a deep dive surgery series. So like went through every surgery that's like available and kind of explained them. But then we also have like a preparing for surgery checklist and a like preparing for recovery checklist, which I think is really helpful. And I think having a video that, one, having information in multiple formats is like super important for accessibility, and two, like a checklist only goes so far. Having someone talk about like what recovery is like and what to expect, I think is like a really, really useful tool to share with patients and community members. Um, so we'll put a link for that under the podcast, your YouTube, Dr. Colt. I feel like my YouTube should be Reverend Dr. Beal, because I'm also ordained.
I love
I don't know why I didn't think of that phenomenal title. But for the gender asset, so you're making it so the new release version is coming out September, October-ish.
Yep, it is in beta testing mode right now. We're in the beginning of September, so hopefully if all the bugs work out by October at the latest. So we're just
Okay.
we're a shoestring crew of dedicated volunteer trans people trying to make it happen.
Okay. Well, maybe this will be our October episode of the podcast, so people can like go to it as soon as they hear this
That'd be
podcast.
amazing.
Yeah, I feel like that's better. And maybe I'll remember to edit this part out, but maybe that's better for like driving traffic to you. But what specifically can people expect? Like, what is the format? Like, what is the structure? Walk us through it.
Yeah, so it's an on-demand online course that has multiple parts of it. I think all in total, it's like 10 hours of content. So it is like going to a conference for a day and a half. And one of the reasons for that, well, a couple of reasons. One is I really wanted this information education to be for us, by us. So it's all trans folks who are involved in the creation and publication of this course. The second part of it is so many people offer 1 hour train you to do a letter classes, which are great and important. But for those of us who are in this work, who want to deep dive, this is really the most comprehensive training that exists for that. It's going to be more comprehensive than the GI courses. It's going to be more comprehensive than pretty much anything else that I'm aware of. So if somebody's like, I want to help people access surgery in an informed way so that they can be well and recover well, this is all the information that you need.
Rad. And so it'll be like video webinars. Is there going to be another workbook? Is there what?
Yep. So the workbook, historically, I've never made it available as a PDF because so many people like to steal stuff and say it's theirs and give it out. But I've gotten over that. I've been convinced by my team to go ahead and so we'll have the PDF as part of the workbook as part of the course. So if you purchase the course, you will get the PDF. You have the option to choose if you'd like to purchase a hard copy and have that mailed to you. So that's part of it. But mostly it's a bunch of our lectures plus so many PDF resources of samples of all sorts of kinds of letters, all sorts of resources, you name it, it's on there.
Amazing. Yes. And yes, highly for all of our listeners, if you subscribe to the QueerCME platform or you end up getting Gender Asset, very specifically there is not any like encryption software that keeps you from sharing your login with other people or giving handouts or downloads to other people. And it's really interesting because like the history of medicine, like we do so often share training and education and resources for free. It's like, oh yeah, like I got this chart note template when I started residency from someone. I'm going to give you like this version of it that like I've tweaked a little bit. And so much of that is shared so freely. And I think that's like a really beautiful part of our field. And it like really disadvantages marginalized people who do a lot of emotional labor to make medicine better for our own communities, because it then means our work, which is like our intellectual property, is like shared for free without paying us for the work or labor that we did creating it. And so while I absolutely understand the desire to like spread knowledge freely because it serves our community, like I like to remind people that my medical education wasn't free. So until my student loan debt is forgiven for that, I actually just need to be paid for my work. And so we are at like, I don't know, nearing $400,000 worth of medical education debt in my life, because I can't actually afford the interest payment every month on it. Because I went to med school during the 2008 financial crisis. So my interest rates are like higher than they've ever been on my mortgage. So while I would love to share all of the things I know and create for free, because I think it would better serve my community, like I just like functionally am stuck in late stage capitalism like everyone else and just like literally can't afford to. And absolutely think Colt should be compensated for his work as well. So I understand that fear around sharing things is like PDFs and downloads, and absolutely make the disclaimer on my own content and ask people to like kindly think about that when they're sharing things that they've found. Yeah, I don't know if you have anything else to say about that.
Yeah, a couple of thoughts. One is I'm blanking on a name, so I need your help with a name. Okay, the person who is part of our badass group, who's in like Rhode Island, starts with an A, I think.
Addison.
Thank you. Addison Tucker. Got it. Okay. Pausing. So two things kind of come to mind. One is, as both ands with healthcare licenses, we also have more liability and more to lose. So for example, if we're in a court case or whatnot, and one of our documents comes out of contexts, where the folks who haven't had the training that goes along with that document try to make it say something it actually doesn't say, we actually stand to lose a lot in that way. So there's also a kind of a safety and risk kind of piece there. And then the other thing is in terms of course accessibility, because I never want finances to be a reason that a queer or trans person wasn't able to get something that I was trying to offer to them. And so I did a consultation with Addison Tucker, who is really great with economic, financial liberation, justice. And so they helped me to create a tier pricing model. So we have kind of a basic cost. And then we have under that is if someone needs or isn't able to afford the full price. And then we have over that for someone who wants to sponsor more folks to be able to access the course. So the Gender Asset funds the platform that it's on called the Gender U. And so that is the online platform that we've been developing since 2018, myself and some trans people of color who are like my family. So Nine, Devin, C, etc. And in order to pay them for their labor and actually make a platform, which there's so much that web design, there's so much that goes into that, right? We have to have capital to do that. And so this course, there are other courses on the Gender U, but this course is the one that has made the most money to make the Gender U continue happening. And so really, in the end, if people are like, gosh, this is a lot of money, where is it going? It's going back to the community, specifically hiring queer and trans people of color to spread, education and information for us, by us.
Absolutely. Yeah, I think Yeah, same. We, you know, at QueerCME, we do, it's not tiered quite the same way. It's, I have like the base course cost for the full course with CE included. And then for people who need a like pay what you can option, it just doesn't include the CE because you know, when it comes down to the money part of things, I have to pay for every CE certificate that's provided. And so I can't actually afford to offer the course with CE if you're not paying the full price. But to like, again, create access at various levels, right? There's the pay what you can option for our course. And then also I do for people who, and the pay what you can is for anyone. Like you don't, it's just like, you just get to pick that option on the checkout. But then for people who are trans identified healthcare workers, I also do just a free day of shadowing with me. And so that's typically, I think that's typically $400. I can't remember what I usually charge for that, but so they can do a virtual clinic shadowing session with me, you know, where they can watch me work, and then we spend time together kind of before and after going over questions and stuff like that. So yeah, definitely in the context of trying to keep our work accessible to people and meet like our own financial needs. And yeah, like my entire team, similarly, we have one token cis member. She's queer. We call her our token. I call her our token cis team member. I don't know if she knows I do that, and so maybe I should check with her. But she's a phenomenal human, and she brings so much to the table. And
she's still gender family because the object of her affections, or she loves people who are a different gender than expected. So it's, you know, we're all gender family.
So and the rest of our team is trans, and she just brings so much to the table in the context of like an anti-oppressive framework as well, and like is just a really phenomenal clinician and human. So that's where that's where the money goes when you pay QueerCME. Right. It's not going to a big corporation or company. It's staying within the community.
It's keeping us able to continue to provide this, you know, this education, this information. And, you know, of course, I have dreams of eventually creating certification programs to rival the ones that already exist that weren't all created and centered by trans folks. So I'm super excited about the direction of the Gender U. And just, I'm so impatient to get the darn course up, but there, you know, so much to deal with. We've gotten APA CEs, we've gotten NBCC for counselors, and we got an ASECT CEs. So now we're working with a company that you connected us with, so we can have CMEs, CNEs, social work credits as well, which I really appreciate. And it's like a part-time job to keep up with all of those.
Yeah, absolutely. Yeah, and I think the broader dream of certification. It's so funny because like I have asked this question on the listserv. This is what, you've been around for some of my listserv debacles. Yeah. So one of the ones I asked one time was like, do we think we should like become a specialty or a subspecialty, right? Because I feel like the ways in which I do gender affirming, and now I'm gonna like say something very inflammatory and probably wish I wasn't saying it on the podcast. But like, right, the ways in which I do gender affirming care as someone who it's my entire practice, I don't do any other care work anymore. Like you do not want to ask me questions about your diabetes or your depression because like my knowledge is 10 years old and foggy, right, is a little different than how my provider, like my colleague providers who do it in primary care and maybe see 10 patients as opposed to 1,000 patients do. And that's not, I absolutely believe gender affirming care belongs in primary care. And I absolutely believe we should have access to care at all different levels with all different kinds of providers. And I don't think subspecializing the care or specializing the care makes that harder. And it's interesting because the conversation in the listserv is that people feel like that threatens that. And I'm like, I never understood that because I was a primary care provider. And so everything I did in primary care practice also had a specialist I could refer to. I just didn't, if I didn't need to. And so I had always thought it would be really interesting if gender affirming care had a certificate, kind of like HIV medicine. So it's like, it's not like you have to be an internal medicine doctor, or you have to be, right, or you have to be an MD or a DO. Like it allows all different levels of care providers and different types of care providers to certify on it, and it doesn't require fellowship training, right? There's like practice experience and like continuing education training options, but I think people got real upset about that question, and a lot of trans people especially feel like it will limit access to care if we do that. And so, yeah, I don't know. What are your thoughts? Now, not to put you on the hot spot or anything.
No, I mean, people have asked me forever, why aren't you an endocrinologist, or why aren't you specialist in this sort of way, and I just say I am a specialist in trans health and sexual health, period. Not only do we have the lived experience expertise, right, but we also have the regular clinical training plus all the extra stuff we did to figure out how to take care of our population. And so I think I'm a both and thinker, right? So I think there is a way to create kind of some sort of certification type thing that does not interfere with access, but takes those of us who want to kind of take our knowledge to the next level and really focus on this area, right, to the next level. And it can be created by both hands who are doing the work already. And so I'm a big fan of that. I always, because I'm family medicine and you're family medicine, for me, it just makes sense to kind of start trying to figure out if our profession will support that, and going from there. But if not, again, we're trying to set this Gender U up so that it can be its own grantor or whatnot of certifications. And I'm trying to work with, I live in a small town upstate New York. There's one of the SUNY colleges here. I'm trying to get a connection there so we can have a university related to it if we need that. And the other piece is working on creating a certification for people who are professional trans people, who need, like, for whatever reason, they're, having a hard time getting employed as a subject matter expert, as a care navigator or whatnot. So working on creating that piece as well. Those are kind of 20-year goals.
Right. Well, and the complication, right, of any time we certify something, besides just people's fears of like, well, then primary care doctors wouldn't do it because there's a specialist, which again, I just don't quite understand that, but like maybe there's research supporting that. And anytime we certify something, we do make it less accessible to people with like intersectional identities, because like there's like the sudden layer of like cost associated with training, right? And so I think if we were to do something like that, keeping that anti-oppressive framework in mind, like you're doing, so that there's like a certain number of free like trainings available in situations like that, so that community members who are less financially resourced still have access to that, so that the voices there aren't all of the most privileged voices. Oh, I actually just learned a new term for systemically undervalued as opposed to marginalized is the term I learned the other day.
Cool.
Yeah. And so going to keep that one in mind. But anyways, everyone should check out the Gender Asset in October. It sounds like it's a training available for all different types of care providers. So everyone on your care team. And we will set up the links for all of that at this podcast as well. But anyways, okay, I do want to take a moment to pause and like have a different episode of our podcast, or maybe just like a continued episode of this podcast. I would love, and maybe we do this another day too. Maybe we just record this another day. I would love to like have a session where we just talk about things that as like trans clinicians, we wish other clinicians knew. Is there anything that pops to your mind about that?
How many hours do we have?
I have like 25 minutes because you have a meeting after this.
I mean, so much, I created a whole 44-hour of a graduate level college counseling class to teach just introduction to counseling or talking to a trans person in a healthcare setting. Uh, there's so much history that people need to know of what they're stepping into, what they represent. There's so much power at play and oppression at play that most people have no idea about. There's a lot of cis folks assuming that, cis heteronormativity is normal. And so if a trans person comes in with a narrative that matches that somehow, oh, I totally understand. Like, yes, you want to be a woman, let's help you be a woman, without really like contemplating on like, what does it mean to be a woman? Who gets to decide? What does this person think about being a woman? Like there's so much that takes years of absorption of conversations with community to get folks where they need to be.
Yeah. Yeah. I feel like I've been doing a talk on like what is cis normativity for a couple of different organizations lately. And it's been like a really it's been one of my favorite talks to do. And I keep like trying to get people to have me come to. I'm like, no, you really want this talk. But I'm like, also, but I need to come in person for this one because like I'm going to talk about like really complex and nuanced things and talk about how all of this is related to white supremacy and how we're all racist. So maybe I shouldn't try to do that on Zoom. Although for some people Zoom is better, right? But I think for a lot of times, like getting to like engage in all of that like nonverbal communication that people are missing, that hopefully, right, back to my listserv debacles, right, that right, that when it's missing, when we don't have access to those nonverbal cues, sometimes the conversation feels like quite a bit more challenging or like inflammatory or blamey even.
Intense.
Yeah. Because I think in reality, right, like these are such important topics and I'm so excited to be talking about them. And I'm like all of 5'2" running around in like 6-inch heels, like throwing my hands around while we're talking about it. And so like it's really right, like even though we're talking about something intense and complicated and nuanced, like I want it to stay like rooted in this like exchange of humans having an experience together. And so coming off the Zoom sometimes helps.
That, just brings memories. So I've been really, I don't know, grateful and excited to be invited to be part of the Indian Health Services like transgender training team and Two-Spirit team. And I would say, a lot of what I want folks to know or hear, right, starts there because they started from the re-indigenizing, decolonizing perspective from like day one. Talk about gender care. And so, and you'll hear some of this on the Asset 2.0 training, but a lot of the kind of creativity and the dreaming of, truly becoming who we are, becoming authentic, self-actualization, the whole purpose of transition is not part of the conversation when you go to a medical provider's office. You want to be a man, you want a beard, here's your teeth.
Yeah.
And so we talk a lot about the process of envisioning or dreaming, because what happens a lot of times is our community just sees some options and says, oh, I want them, but doesn't, a lot of times we haven't been invited to sit back and dream. So for example, I'll, when I meet with patients and when I do the surgery evaluations, I'm like, all right, if you could wake up tomorrow and there were no laws of science or gravity or anything, and you could totally morph in your shape, in your sound, like your hair, literally anything, when you wake up tomorrow, if you were feeling more at home in your body, what would be the same and what would be different? And so in that way, that's, I just started that practice and I learned that that's an indigenous like Two-Spirit medicine. And I was like, oh, cool. I guess I am practicing weird, but cool. And so in that way, people will still answer me with, oh, I want top surgery instead of I want a flat chest.
Mm-hmm.
Right? Because they're so stuck in that. And so I
Mm-hmm.
try to remove that to help them really open the dreaming, because that's part of our sacred power as trans people, to really reflect on how to become at home in our bodies, how to become authentic, how to do the self-actualization process, and to allow that to be a journey and a process that may change over time. But when I get folks there, then from the kind of Western medicine that we're doing, then I can sort of make recommendations to help them achieve those embodiment goals. So embodiment, I think, is a huge concept that is relatively new to trans spaces, but it comes from indigenous teachings. And so I think like that's a big piece that I'd like people to learn more about. And and both Dr. Jimenez and I are both part indigenous. And so we bring that to the Asset 2.0 training. And so I think that is something I'm most excited about.
Yeah.
I said that in the first thing, but I'm saying it now.
No, whatever. We might just keep them all together, so it doesn't really matter. It depends. But yeah, I think it's like such a it is such an interesting thing. I'll read other clinicians' notes, and like there will be like a goals of care section, and it's like start testosterone. I'm like, but what was underneath the start testosterone? Like what am I actually trying to achieve with the testosterone? Right. And so it's such an important part of the work. And I think like helping people like really verbalize what it means to them. It's so important even from the Western medicine standpoint, because if people can really verbalize what they're looking for, it really helps us understand if we're like objectively supporting their care and their treatment and achieving their goals. And so we definitely have all had those patients who are like, you know, I don't know, been on estrogen for 6 months and like levels seem appropriate, testosterone's well suppressed, and they're like, nothing's happening. You know, like I'm not noticing any differences. And I'm like, okay, like either you have some interesting endocrinological like condition that I'm like want to learn about, or like we're not doing a good job of catching what is changing. And if we started off without being able to say what we wanted to see, it's going to be harder for us to catch what is changing. You know, so it really, I think, helps support like just setting realistic expectations and really objectively understanding whether or not we're achieving them.
Yeah. And I think the big thing that we're doing here, right, is when we think about the history of gender care, right? First, it was about like, prove you really are a true transsexual. Give me the story, and then I'll give you hormones, without even asking, do you want boobs or a beard? Like without even asking those questions. Like you pass the man or woman test from a cis person to a trans person, which that's the whole thing, right? And then from there they move to, okay, diagnosis, pathology, right? So meet the criteria for gender dysphoria for access, without ever asking us our embodiment goals, without ever allowing us to dream. And so I think really what I would like cis clinicians, or just clinicians at all who are getting trained to come into this work, to know that history, you know, and to be aware of when you're being trained, like if you're hearing vestiges of that, right? And then help us to kind of move to that person-centered, individualized, you know, customized treatment plan that everyone deserves, because everyone's, you know, their own person. And remembering what's the whole purpose of whatever transition is: self-actualization, authenticity, right? So figuring out a way to recenter that into the care, I think, is kind of where I will hope that people are moving. And especially as we center trans people, both and in these educational discussions, especially, I think people will gravitate in that direction.
Right. And I think it was so interesting, you know, I was practicing like on my own out of my house, you know, like a few years ago, right? And then I sat down with like you and Jen Hastings, and it was like, it's like 3 gender diverse people practicing trans healthcare all came to like practicing in the same style. Right. And there's this term metatherapy, which is like another talk I sometimes do, but which that term comes out of the speech language pathology world. And it's very specifically the therapeutic dialogue an experienced clinician develops to move through a clinical encounter efficiently and effectively, right? And how, so it's like that scripting that we all end up with, like when we've done this for a while, and how like the article about metatherapy and speech language pathology is like, we don't teach this to our trainees, and it's kind of silly. Like we should be teaching this because they won't stick with this word for word phrasing forever, but it will help them get to experience practice more quickly. Right. And I think, you know, for me as a person who was like in independent practice, like always kind of wondering, like, am I just making things up over here? Like, right. And when what we do is so different than what like the general body is doing, right? And we've talked about, I don't know if you were in the group, we talked about this last time. I've been really sitting with the fact that like if my practice of medicine is truly anti-oppressive, it's going to make most of my colleagues uncomfortable. And so then it becomes very challenging for me to sort out when is my practice making people uncomfortable because it's unethical or unsafe medicine versus anti-oppressive medicine. And so, right, it's so, I think, affirming to me as a practitioner who's like not in a large group practice and not surrounded by, although we have more practitioners now at my practice, but we're still all remote, to like engage with other colleagues that I respect and admire and recognize that like we've all come to like practicing in a very similar style and approach. Right. And there's right, some of this like probably like sacred trans wisdom like infiltrating into the practice of medicine, and how we're doing that is often how I think about that.
Yeah, it's real. And I think, you know, if we are ever to create some sort of certification or something like that, like I think we can genuinely argue that our approach is fundamentally different than all of the different bodies that make guidelines that are recognized.
Yeah, right. A little secret sauce. But yeah, I do think it's like such a complicated and nuanced thing that as I'm doing like more and more trainings for more and more organizations, and I'm like, hey, yeah, let's talk about cis normativity and like how that's rooted in white supremacy, and like let's talk about how any actions that we take that support these things are then like essentially racist, misogynistic, and transphobic. Right. Like that's asking people to look at like everything they do, and it gets really uncomfortable. And it's like, oh yeah, right. And if practice is like rooted in like radical bodily autonomy and empowering people to have like decision-making rights around their own body and their own healthcare, that like suddenly changes like the structure and experience of medicine in a fundamental way that is very uncomfortable for most people.
Yeah. And then except my patients who come in and are like,
what?
Wow.
Yeah, absolutely. I know. One of my very sweet patients was like messaging me. They were like, wait, I sent like a prescription to a pharmacy in Florida that during the time that the injunction was in place. And so I could. And then like there were issues with the pharmacy, and literally before I could like call the pharmacy and sort them out, the law changed again. And so I like sent it to a mail order pharmacy. Like you have to pay cash, you can't use insurance with that. And they were like, I don't understand. You made such a big deal out of me being in charge of my own healthcare, and then you sent this to this mail order pharmacy without checking with me. And I don't, you don't have money to pay for my visits and my prescriptions out of pocket. And I'm like, I'm so sorry. I should have checked with you first. Like absolutely, we'll comp the cost of the prescription for this time. They were like, why didn't you just call CVS and sort it out? And I was like, the law changed and I couldn't. Like, and I'm sorry I didn't make that more clear for you. But they were so cute. They were like, you made such a big deal about this, about me being in charge, and then you fucked it up. And I was like, you're right. I'm very sorry I did. And
but I love that like we're able to keep each other accountable, because I think, you know, what I would have learned from my like Indo-Cis normative, heteronormative medical school education, right, is like, oh no, like that, kick them out of your practice, or like, you know, something like that. And it's just it's a fundamentally different kind of way of thinking about people, about care, about anti-oppression, trauma inform, all of the things that we do. And I think as as we talk about this, of course, I think this is helpful for all people, right? Not just gender femme and queer and trans people. So I think I think about these things all the time.
Yeah. Yeah. Right. I was like, yeah. Like, here's my patient, like saying, like, you said you were committed to me being in charge, and then you made it in charge decision. I was like, I did. You were right. I thought I was making a good decision because I thought I was getting you the thing you needed, but I should have checked with you first. Absolutely. And I think it's so important to, like, and we don't have time to get into this today, but in the context of like being both ands, right? And this is like, I think very rooted in Indigenous healing practices as well, is like how separated healers are in Western communities from the people we care for, and how like we really aren't in community with the people we care for, and how what a very different framework that is for healing than like how healing has been approached for generations. And how as like a both and, oftentimes like you can't replicate that Western model of not being in community with the people you care for, because like it gets very small,
very fast.
very fast. Right. And so what it means to like, what is so scary for Western healers about being in community with the people we work to heal?
Yeah.
You know,
a fundamental question that it's rooted, of course, in colonization. Dr. Power, these are the people that make all the decisions, and we're literally going to try to go back to replicate healing that's been working for generations and generations, that's been intentionally erased, right, and devalued or undervalued, depending, right? So, and I think that's, again, why I'm just so grateful that so Kelly Blair is my two-spirit mentor and is really introducing me to this world and of, working with Indigenous folks, working with learning two-spirit medicine. And I was always like, are you really sure that I'm two-spirit? I think I have some remote connection to indigeneity. My mom always said that we had this, I have nothing. And they're like, the way you talk about stuff, you are two-spirit. Like, I don't care. Like, they're like, I don't care if it was another lifetime. I don't care if it's a fifth, and I'm just like, okay, the ways of knowing, right? There are all sorts of ways of knowing. And Kelly's like, I know that you are two-spirit because the way you come to this practice. And I was like, okay. And so because of their seeing me in that way, right, that's how I got connected with Indian Health Services, and learning that the work we were already figuring out about embodiment has already been central to what they've been talking about forever.
Yeah. Are you working with Itai and Hannah? I love them. They're great.
They really are.
Yeah. Phenomenal humans. Well, amazing. Thank you so much for joining me for the podcast today. It was all kinds of topics all over the place. Hopefully it's helpful to people. Definitely Gender Asset. Check it out. I know we're checking it out. Do you have anything else you want to say to people before we let them go?
No, thank you for supporting the work that we're doing and helping us get the word out, and keep taking care of people and yourself.
Okay, I'm gonna stop the recording. For